Good morning. I'm Anand, I'm one of the senior residents. I'll be presenting our imaging cases today. We'll begin with case one. We have a 29-year-old woman who initially presented with blurry vision in both eyes, right worse than left, for about a week. On presentation, her vision was count fingers in the right eye, 20/60 in the left, and on anterior exam, she was noted to have mild soft periorbital edema on the right, in addition to serious chemosis without injection in both eyes, right worse than left. Dr. Shalai.
So we have a pseudocolor wide field fundus photo of the right eye, decreased central acuity to counting fingers. The media itself appears clear. The disc on the inferior aspect looks a little full here. Maybe the vessel is going through an elevated area down here. I don't see any cotton wool spots or disc hemorrhage though. In regards to the vasculature course, they seem to have a tortuous appearance to both the veins and the arteries. And considering that the patient is pretty young, these arteries are fairly attenuated for a young patient like this. In addition, there is a focal spot of maybe splinter or a blood hemorrhage here. I don't see any more in terms of hemorrhage. And our attention is drawn to the posterior pole, where we have this area of what appears to be diffuse hyperpigmentation of the posterior pole, and within it we can appreciate these foci of yellow, white, deep lesions, either deep retina or choroid, within this area of hyperpigmentation and slightly passing the hyperpigmented area.
Great. Thank you. And the left eye.
So same imaging modality of the left eye. Central acuity is a little better here. The patient was less symptomatic in this eye. Media, again, is clear. The disc, once again, the inferior aspect looks a little full to me. The vasculature, also arteries and veins, appear to have a little bit of tortuosity to them. Again, we appreciate that attenuated appearance of the arteries for a young patient like this, and similar deep hypopigmented spots that we see. They seem to be less extensive, but they are localized to the posterior pole. We can see them both nasally and also temporally, a few spots in the macula. The foveal reflex appears much more distinct in this eye compared to the fellow eye.
Is this real or not, these little white dots along the arterioles here?
Those were seen clinically, I believe.
So we have a wide field fundus autofluorescence of the right eye. Our attention is drawn to this background hyper-autofluorescence corresponding to those hyperpigmented pigmentary changes we were seeing in the posterior pole. And within it, we have this granular speckled appearance of intervening areas of hypo and hyper autofluorescence. The retinal mid-periphery and far periphery appears relatively intact, and there's this one focus of hypoautofluorescence corresponding to that dot hemorrhage that we were seeing. Same imaging modality of the left eye, similar changes in autofluorescence patterns here, much less than what we see in the fellow eye, but we have these intervening areas of hyper and hypo autofluorescence in the superior retina, inferior retina, a few spots in the macula itself, and also nasal retina. Once again, the mid-periphery and peripheral retina appear relatively normal.
Great, thank you. We have some fluoresceins.
So fluorescein angiogram wide field of the right eye, 28 seconds. We appear to be in the arterial phase, relatively good filling so far. We do appreciate the tortuosity in the arteries, as we noted previously. In regards to the overall choroidal perfusion, it does appear somewhat patchy. We are fairly early, so we'll see how that lights up later on. And we're starting to get these foci of hyperfluorescence, which appear to be, at this stage, probably deep and localized to the choroid in the temporal macula.
Thanks. Later frame.
37 seconds, we're at the AV phase. Good retinal vascular perfusion, again, appreciating the tortuosity. And those foci of hyperfluorescence seem to have this overall lobular pattern and correspond to those pigmentary changes, autofluorescence changes that we were seeing previously. And they do appear to be deep, possibly localizing to the choroid. I don't see anything in terms of macular hyperfluorescence or leakage, and the disc looks quiet at this point. Going to 1 minute 7 seconds, the perfusion overall in the retina looks good. I don't see much in terms of peripheral non-perfusion. There do appear to be some maybe microaneurysmal changes in the far periphery of the retina. Might be non-specific changes in the very peripheral retina. And overall, again, that sort of granular, lobular appearance of hyperfluorescence localized to the posterior pole. Maybe they're expanding somewhat compared to before. Again, don't really see much in terms of macular edema or hyperfluorescence, and the disc still looks quiet.
Thank you.
So moving along, there is some expansion of these hyperfluorescent foci, suggesting that there may be some leakage at the level of the choroid.
Then final frame for the right eye.
Yeah, so similar appearance, similar expansion of these areas. There does seem to be some choroidopathy here.
Okay. And the left eye.
So 1 minute 26 seconds. Looks like we're at past the AV phase at this point. Again, retinal vascular perfusion itself seems to look good, and our attention is drawn to similar areas, albeit less extensive, localized to the posterior pole mostly, and deep foci of hyperfluorescence, again, probably localizing to the choroid at this point.
And then a late frame.
Again, we have similar appearance, expansion of these areas suggesting some leakage. The disc itself looks okay. No macular edema.
We have an OCT.
So we have a horizontal OCT going through the right fovea here. Looking at the infrared image itself, the retina seems to have this somewhat wavy, undulated appearance, and if we correspond it to the B scan, it seems to correspond to these somewhat outer retinal folds, perhaps, that we see. A lot of disorganization of the retinal laminations here. The vitreous appears optically clear. The choroid has, there's not a lot of definition of the choroidal vasculature here. It doesn't look like a normal choroid to me, and that was suggested from the prior imaging as well. Looking at the actual retinal layers, the inner retinal layers seem to be a little more intact. However, there is a little bit of loss of definition between the layers itself, maybe owing to this intraretinal fluid and edema that's going on. In addition, we see this large area of subretinal fluid as well, and some disorganization of the outer retinal layers. So trying to figure out the layers itself. So if we think this is the RPE, there's some central RPE clumping here, and then the ellipsoid zone and external limiting membrane seem to have this splitting from the other layers of the retina, causing this waviness and the folds to the outer retina itself. Maybe some fibrinoid reaction here as well in the subretinal fluid too. So we have an EDI image. It appears to be the same eye, and I guess we can comment on the choroid here. So definitely some loss of architecture. We don't really appreciate the definition of the choroidal vasculature here, and it's very diffuse. I don't see any specific mass in the choroid, but it is very diffuse loss of architecture in the choroid.
We have the left eye.
So similar imaging modality in the left eye, much more normal appearing. Again, the vitreous is optically clear. Here we appreciate the choroidal vasculature a lot more, though this is an EDI image. We don't really see the posterior aspect of the choroid a lot, so I would say this choroid does look thick to me comparing to the thickness of the retina. Looking at the retinal laminations itself, they are much more normal compared to the fellow eye, and these hyperreflective areas, given that the image is tilted a little bit, it just might be Henle nerve fiber layer artifact, and maybe some disruption of the outer retinal layers here towards the disc, corresponding to these changes we see on the infrared image. And going further down in the macula, we have a horizontal cut capturing this somewhat, again, undulated, elevated appearance of the retina here. And we see on the B scan, it does correspond to a pocket of what appears to be subretinal fluid.
So based on the information that you have at this point, what kinds of things would you be thinking about for this patient?
Yeah, so we have a young patient with evidence of bilateral serous detachments and choroidopathy. I would be thinking of pachychoroid disease, central serous retinopathy, aggressive form of central serous in this point. Maybe a case that I might look into even endogenous steroids if other differentials were not the case. Malignant hypertension is something that can definitely cause bilateral choroidopathy like this and serous detachments. Along the same lines, if the patient were pregnant or they were hypertensive complications of pregnancy, like preeclampsia or eclampsia, it could cause a similar picture. We've talked about medications that can cause bilateral serous detachments in this conference. So, MEK inhibitors, checkpoint inhibitors, erectile dysfunction medications could cause bilateral serous detachments like this. And uveal effusion syndrome, especially with that almost leopard spot appearance on the autofluorescence, could definitely cause a clinical picture similar to this. In terms of inflammatory causes, VKH and sympathetic ophthalmia can cause bilateral serous detachments similar to this maybe, though it didn't seem like our patient had any evidence of intraocular inflammation. And maybe an aggressive posterior scleritis could cause subretinal fluid and choroidal thickening, though it would be unusual for the patient not to really complain of pain and come with decreased vision. And neoplastic processes, something like B-dump could cause that leopard spot-like appearance in both eyes, though the patient's very young to have a diagnosis of cancer, though it may happen. And then choroidal masses that could be exudative, like melanoma, hemangioma, though it would be very unusual to be bilateral like that. That would be my...
Does she have any history of paraproteinemia?
She did not.
I'm just trying to think of some way to tie this together with the chemosis that you described initially, and thinking maybe some of those exudates are oncotic in origin.
Yeah, absolutely. So you hit on a lot of what we consider, Dr. Chalet, central serous, malignant hypertension, as well as toxemia of pregnancy. We did consider inflammatory etiologies like VKH and sympathetic ophthalmia, but given the absence of intraocular inflammation, these were much less likely. We also considered DIC and hematologic malignancies, but in the absence of retinal hemorrhages, these were also considered less likely. And then I believe you spoke to some of the others on the list. What additional historical information would you ask the patient?
Yeah, so the history is going to be very important here. I think just the onset of the symptoms, how fast they developed, and what the course was is going to be helpful here. Knowing if there's any associated symptoms like headaches, seizures, things like that, the medications that the patient's taking, and obviously the clinical exam and the ocular history are going to be helpful.
So on history, we learned that the patient actually presented with bilateral vision changes and chemosis at around 29 weeks gestation. This was her first pregnancy. She was seen by a local ophthalmologist and referred to a hospital for severe hypertension, also found to have proteinuria and bilateral lower extremity edema. She was diagnosed with preeclampsia with severe features, underwent emergent C-section, delivered a baby girl, and was subsequently managed with systemic antihypertensive agents. And she was subsequently instructed to follow up at Wills, where she presented about a week postpartum with continued visual changes and chemosis. Blood pressure was 162/107 on 2 antihypertensive agents. So preeclampsia and eclampsia can cause associated choroidopathy and retinopathy. Preeclampsia itself is an obstetric complication defined as new onset hypertension and proteinuria with or without other evidence of end organ dysfunction occurring after 20 weeks gestation or postpartum in a previously normotensive woman. It's estimated to complicate around 3 to 5% of pregnancies, and the exact pathophysiology is not entirely understood, but it's postulated to be related to abnormal placentation resulting in chronic placental ischemia with the release of systemic factors causing global endothelial dysfunction and arterial spasm. Fundoscopically, it can be characterized by arterial narrowing, choroidal ischemia, RPE dysfunction leading to serous detachments, as well as retinal hemorrhages and cotton wool spots. Vision changes are seen in roughly a quarter of preeclamptic patients, with serous detachments occur in only about 1%. And management involves delivery of the fetus as well as the placenta, and then management with systemic antihypertensive medications. And most patients will recover vision spontaneously over the course of several weeks, though some do have long-term visual sequelae related to RPE necrosis. So the choroidal vasculature is believed to be more sensitive to hypertensive changes compared to the retinal vasculature. And this is thought to be related to differences in autoregulatory mechanisms and the shorter course of the choroidal vessels themselves. This study was a retrospective case series published in the journal Eye, basically comparing the clinical features of serous detachments between preeclamptic patients and patients presenting with malignant hypertension. And interestingly, the study found that blood pressure parameters were overall lower among preeclamptic patients, but hypertensive retinopathy features were more common among patients presenting with malignant hypertension. And visual acuity outcomes tended to be better among preeclamptic patients compared to the malignant hypertension group. So our patient was seen in follow-up 1 day, 1 week, 2 weeks, and then 6 weeks after her presentation to Wills. At her 6-week follow-up, her vision had improved to 2100 in the right eye. And as you can see here in this image, she had significant resolution of her subretinal fluid, but did have mid-peripheral pigmentary changes. And as we see here on these serial OCTs, resolution of subretinal fluid in both eyes, but then she was left with these drusenoid subretinal deposits here. The vision was 2100 at her final follow-up. Just a question for the attendings. How closely would you follow this patient moving forward, and how would you counsel her on her risk of visual complications with future pregnancies?
I think we're already seeing improvement in the vision. We can start spacing out her visits. She definitely needs to continue to follow up with her primary and her OB-GYN to manage the hypertension. One question I had was in terms of those little deposits there, whether that's going to represent RPE necrosis down the line. It'll be interesting to see how that progresses. In terms of future pregnancies, I'm actually not sure. I haven't had a patient that has had preeclampsia and then has had a subsequent pregnancy to monitor that. I'd be curious to see what the other attendings have noted with that.
I think the vision can continue to improve. I mean, 6 weeks, it's already 2100. You're right, it depends on the RP necrosis, but I would give it another 6 to 8 weeks and see where the vision ends up. And I agree with the Ajay. I'm not familiar with, future pregnancies, how they need to be followed, but I'm sure obstetrician will follow them much more closely.
Sure. Moving on to case 2. We have a 17-year-old male presented with decreased vision in the right eye for 2 weeks. On presentation, vision was 2200 in the right eye, 2025 in the left, and anterior exam was normal. Dr. Light?
So we have a wide field pseudo-color image of the right eye. Vision is 2200 as mentioned. Overall, the media opacities are minimal, maybe a little bit of some mild haziness. Attention's immediately drawn to the disc, where the superior margin is a little bit obstructed, not very sharp as is the rest of the disc here. The macula itself looks clear of lesions. The vasculature is of normal course and caliber, though superiorly we lose some of the definition and difficult to tell if there's maybe some attenuation up here. The far periphery looks essentially unremarkable, no lesions. And then clearly, along the superior arcade here, there's this area of whitening. Given the obfuscation of the vessels themselves, difficult to tell if this is just intraretinal or if there's maybe some pre-retinal or vitreous component to it.
Thank you.
Okay, never. You just showed me. Never mind.
So zooming in a little bit, we get a little bit better delineation of this area of whitening here. Again, there's really quite a bit of obstruction of the vessels here, so I would imagine there may be some overlying vitreous opacity here. It almost looks reminiscent of a large cotton wool spot, but again, the central macula itself looks relatively spared, though maybe there's a little bit of loss of some foveal definition here, and maybe a little bit of some mild vascular tortuosity in the area around this lesion here.
So there's hard exudates here, but looks like they're tracking all the way down to here, doesn't it?
Yeah.
And pseudo-color wide field of the left eye, visual acuity is 20/25. Here I can say media looks clear, discs look sharp, macula and periphery look normal, and the vasculature looks normal as well. And this is an autofluorescence of the right eye. Again, you can now see focused around this lesion around the proximal superior arcade. There's maybe a little bit of some attenuation of the fluorescent signal right adjacent to the vessels, but then a clear area of hyperfluorescent signal surrounding that. Again, you can see a little bit of this tortuosity of the vessels, again highlighted in the autofluorescent image. Otherwise, the peripheral autofluorescence pattern looks normal. And in the left eye here, this looks like a normal autofluorescence pattern.
Some fluoresceins.
So frame at 21 seconds, looks like we are in the laminar venous phase here. There is overall pretty good perfusion, though. I notice that there's some delay in some of the venous filling here temporally, but nasally there looks to be good perfusion throughout. Attention's drawn to this, again, area that corresponds to that hyper autofluorescent signal where there is hyperfluorescence, and it appears to be deep to the vessel, so possibly the level of the RPE choroid could be, given this early frame, a window defect versus early staining here. There is some hypofluorescent signal in the center of this, unclear if that's due to possibly blockage versus truly decreased perfusion there. And again, the macula itself, at least at this phase, doesn't show any frank macular edema. The disc is a little bit blurred again superiorly, but too early to say whether there's disc leakage.
We have a later frame.
And moving on a little further now in the full AV phase, again, still this area of likely staining versus window defect, as I pointed out before. One could maybe argue there's a little bit of some attenuation in the far periphery here, a little bit of non-perfusion, though it's mild. And I don't see that any of the vasculature itself is showing any prominent leaking. And again, still no macular edema centrally. And I think similar appearance here, not many changes. Maybe this area is starting to expand a little bit, suggestive of some edema here. And again, a few seconds further, similar appearance. The disc actually does look a little bit hyperfluorescent now. I would probably start calling that some disc edema.
And then a late frame.
Yeah, so again, still fairly localized to the disc and this lesion that was pointed out before. No other areas of diffuse leakage.
Thank you. And the left eye.
Full AV phase in the left eye at 1 minute 18 seconds shows intact perfusion throughout. Disc looks not hyperfluorescent, and the macula looks normal. This looks like a normal FA of the left eye.
Yep. Get through that.
OCT scan through the right fovea, infrared imaging. You can see this hyporeflectant signal here corresponding to the lesion that we were mentioning earlier. And then attention to the B-scan raster image here. You can clearly see there is indeed some vitreous opacity here, likely cells. The inner retina, overall the lamination patterns are well preserved, though there's some contour change here as we go nasally towards the lesion, maybe some loss of definition here of the inner retinal layers. Temporally, the outer retina looks essentially normal, and the choroid, it looks to be of normal thickness, but there's clearly subretinal fluid under the fovea and extending nasally out towards the lesion that you've highlighted here.
Some cuts through the lesion itself.
Yeah, so again, hyporeflectant signal here on the IR through the lesion. And now we can see on the raster scan here that there's definite intraretinal thickening. Again, focal, maybe be so bold as to call that even vitritis, vitreous opacity overlying the lesion. And again, some subretinal fluid here and a lot of shadowing artifact underneath it.
And just another cut.
Similar sort of findings here.
Okay.
And again, left eye, as per all the other imaging, this looks like a normal OCT through the fovea of the left eye.
So with the information that we have at this point, what kinds of things would you be thinking about for this patient?
Yeah, I mean, so in the initial anterior segment exam, there was no note of at least anterior vitritis, but I think we're seeing that there's clearly some mediopacity here. So I'm thinking that inflammatory and infectious lesions are top on my differential. You know, things that can cause focal intraretinal thickening and overlying vitritis, I'd be concerned about, as a toxoplasmosis would be one in particular. Sometimes viral retinitis can also look similar to this, though there isn't as much maybe vascular leakage and vasculitis as I would expect. But again, in a young patient, would be concerned about an ARN or a PORN sort of presentation. Other inflammatory conditions like sarcoidosis also could be considered. Tuberculosis probably less likely unless there's a history of exposure. And then I would also just consider maybe vascular sort of lesions. Again, it's not typical appearance of a cotton wool spot, and it's quite large, and the intraretinal thickening is a little out of proportion,
Sure.
But you could also think of focal ischemia. And then syphilis, I think, is also something that we always keep on the differential. Unlikely to be like a fungal endophthalmitis, just given the left eye is completely uninvolved, and unless he has risk factors, I mean, you might want to consider that as well. But I think that would be kind of my short list of things to think about.
Great. Thank you.
I would put cat scratch in there as well, because it's right by the disc, and sometimes you can get little kind of granulomatous lesions right by the disc too.
Great, thank you. You hit on a lot of things we also considered. We also had serpiginous choroiditis on the list, given the juxtapapillary location, but the appearance of this lesion would be atypical for that.
It's not going to be serpiginous choroidopathy because it's not a choroidopathy, it's a retinopathy. And serpiginous choroidopathy doesn't give you inflammatory cells, so you can eliminate that.
Other things to consider, neoplastic lesions. But with the vitritis, it's not likely to be neoplastic. But the ones that you might consider would be a hemangioblastoma, but they're not as yellow as your picture showed, and an astrocytic hamartoma, but it usually doesn't cause exudation, but astrocytoma can lead to exudation. So you just keep that in mind, even though I do think this is inflammatory or infectious.
Thank you. So with this differential in mind, Dr. Light, what kinds of questions would you ask this patient?
Yeah, I mean, so I would want to kind of pin down whether or not this patient has risk factors for some of these infectious etiologies. So, sexual history, any IV drug use, any history of herpetic infection, cold sores, that sort of thing. Any exposure to cats or any raw meat consumption, if you're thinking about toxoplasmosis. Otherwise, from a vascular perspective, young, assuming relatively otherwise healthy person, but you would want to ask about any history of hypertension or other kind of things that might explain why they have a lesion like this.
So on history, we learned that the patient's only past medical history was asthma. He denied any prior episodes of ocular inflammation. His family was from Puerto Rico. He did travel there recently. Denied owning any cats, but recently acquired a new puppy. What workup would you be interested in?
Yeah, so I think I would personally want to play it safe and probably cover for a couple of etiologies until we have a more definitive diagnosis. I think given the concern for possible toxo and versus viral, I think I would do an AC tap to send for PCR for viral and toxo signatures. And then I would probably treat empirically given the near location to the macula in particular, I would probably treat with both fuscarnet and clindamycin to cover both of those etiologies, though I think viral is maybe a little lower. And then I would want to get some serologic testing, obviously syphilis testing, quant gold. You could consider toxo serology, though I don't know if it's, if you were trying to really rule it out, it might be helpful, but given I'm not sure how useful it would be otherwise. And then, again, because we're considering syphilis, I might want to get an HIV test as well.
Thank you. So the patient had the following labs drawn, CBC, syphilis testing, quant gold, toxis serologies. He also had an aqueous tap with the ocular PCR panel sent. And you sort of mentioned already what your empiric management would be. So he was started on oral Bactrim given high concern for toxoplasmosis. And he did receive intravitreal clindamycin, but did not receive intravitreal fuscarnet. So his workup came back positive for toxo IgG. He was IgM negative. His PCR panel, however, was negative, and concern was high enough for toxo that he was actually tapped a second time on follow-up, and PCR was negative ×2. This is just an analysis looking at 187 samples from eyes with suspected toxo, and it found that the sensitivity for PCR of intraocular fluid was only 69.4%, and the negative predictive value was 93.2%, suggesting that a negative PCR alone is not enough to rule out ocular toxoplasmosis. So given high concern for toxo, a patient was continued on Bactrim. He was also started on systemic steroids with plans to taper. Just a question for the attendings. How early would you feel comfortable starting steroids in a patient like this? And is there a role for either periocular or intraocular steroids as opposed to systemic?
So if you're going to use steroids, you can do it in a couple ways. The most important thing is not to use triamcinolone in these cases. You don't want to have a pharmacokinetic mismatch of your antibiotics and your steroid, because unopposed steroids in toxoplasmosis is a really bad thing. So if you're going to do a steroid, I would use dexamethasone intravitreally. You can do that with clindamycin. You can't put them in the same syringe, but you can do them as consecutive injections. Oral steroids would be reasonable. There's not a whole lot of inflammation going on there. Did she have any anterior chamber cells?
He did not.
So it's not surprising that the tap is going to be negative. If you don't have cells, you're not going to have a positive PCR. So it's not all that unexpected that the tap was positive. I think the combination of the positive serology and the clinical findings are consistent enough to make me think this is toxoplasmosis. I really wouldn't think this is viral. I don't have an objection to doing the prednisone, but you could equally argue that just treating with the antibiotic therapy, especially having had the clindamycin, would be reasonable enough. You know, a young person's probably going to tolerate prednisone well. It's not going to cause any problems with the toxo as long as they're on the anti-toxo therapy.
Great.
But I'm not sure you had to start it.
Thank you.
No contraindication for starting prednisone, right, with Bactrim, right, JP?
I'm sorry, no contraindication to...
To start it together, the prednisone
No, that's fine to do. So if you look at the American uveitis surveys that Gary Holland did about a decade apart in the 90s and early 2000s, the initial survey had people using steroids a lot more than they did in the second survey. And there's no good control clinical trials that show efficacy for oral steroids. There's no controlled clinical trials for intravitreal dexamethasone either. But I think people use them less frequently than they used to. There's not a lot of vitreous inflammation. There's not specific optic disc involvement. I don't usually go that route.
Dr. Dunn, I have a quick question. Should we be getting serum serologies in addition to AC taps always, or should we think about it more if we feel like our AC tap is going to be less informative because there's not a lot of anterior inflammation?
Yeah, so I think if you expect a lower yield, it's reasonable to get the serology. It's an inexpensive test. It's obviously easy to do.
But it shouldn't be something we're getting on every AC tap. We're getting for suspicion for toxo.
Correct, right. I mean, it's your clinical suspicion that's really going to drive it, because your baseline serologic prevalence of toxoplasma IgG is going to be probably at least a third in the population. So it's going to have a high false positive rate if you just got it on everybody.
So at 2 weeks follow-up, our patient's vision had improved to 20/70. He also had some improvement in the overlying vitritis. And on serial OCTs here, we see that by 6 months follow-up, the vision was 20/50, and he did have this chorioretinal scar juxtapapillary.
That, if you go back one slide, so it's a nice example, those top two images of what is sometimes, you'll see it on the chart as vitreous chorotic precipitates, which is obviously a misnomer, but those are classic vitreous precipitates, which are not diagnostic, of course, of toxoplasmosis, but they're a nice feature of it. So you see those deposits right on the posterior vitreous face. And sometimes you'll see, when you look in, you can see overlying inflammation. If you look out in the periphery, it might be a crystal clear view.
JP, can I ask, I've had a run of pediatric toxo patients like this where they have like a focal lesion, not like an eye filled with vitritis. And do kids present a little differently or kind of like this without significant vitritis here, or is it just a coincidence?
No, that's a good point. I don't know the literature on that, but my experience is similar, that when kids have toxo, I see less of the sort of headlight in a fog appearance. I see that more in older adults. And in kids, it's more localized lesions without the severe inflammation. And I'm not sure why that is. You'd expect that kids would mount a significant host inflammatory reaction. So I'm not really sure.
So ocular toxoplasmosis is the most common infectious etiology of posterior uveitis. It's caused by Toxoplasma gondii, which is a single-cell intracellular parasite. Cats are the definitive host, but humans are intermediate hosts, and infection occurs either through ingestion of infected waste material, contaminated soil, or undercooked meats. Seroprevalence is relatively high in North America and much higher in Latin America and developing countries. This was a case series published in Ophthalmology looking at the clinical features across 154 patients. Mean age on presentation was 30. Most patients presented with evidence of prior chorioretinal lesions. Macular and juxtapapillary lesions were not uncommon. And recurrence was not infrequent, occurring at a rate of about 60% at a mean interval of 3 years. And roughly 1 out of 4 patients ended up with vision less than 2200 in at least one eye. Management, as we've hit on, classically involves the administration of systemic pyrimethamine and sulfadiazine with folic acid supplementation, but alternative regimens include azithromycin, clindamycin, and double-strength Bactrim. And then corticosteroids are typically reserved for vision-threatening lesions.
Pyrimethamine is potentially marotoxic, and you have to monitor the white count if you go that route. Sulfadiazine is extraordinarily expensive, and most people now will use Bactrim instead. There's some theoretical or animal studies that suggest that sulfadiazine might be more effective, but there's no there's no actual clinical data to suggest that's the case. So, if you want to bankrupt the patient, put them on sulfadiazine.
So this was a randomized controlled trial published in AJO, looking at the role for prophylaxis with Bactrim versus observation in patients with recurrent ocular toxoplasmosis, and found a significantly lower rate of recurrence in patients that were prophylactically treated. Dr. Dunn, this is a question for you. So in our patient who has not had recurrent disease but does have a juxtapapillary lesion, is there a role for long-term prophylaxis with oral Bactrim?
So I don't know that I would put a patient on prophylaxis for a single episode. Bactrim as a 3-time-a-week regimen is generally well tolerated. So I don't think you could argue against it, but I generally don't do it for the first one. I worry less about peripapillary lesions than parafoveal lesions. Peripapillary lesions tend to cause less long-term problems. Parafoveal, once you have foveal tissue destruction, you're never going to get it back. So I'm not sure that I would start it in this case. There was just a recent chain of discussion on the American Uveitis website about if you have a patient who needs prophylactic therapy and can't tolerate Bactrim, what would you use? And the consensus was that azithromycin, 250 milligrams, and every other day or 3 times a week would be reasonable in that case. Also tends to be well tolerated.
The other thing to realize is several of these authors are from Brazil, and when we talk of toxoplasmosis, lots of times people kind of lump them all together. There's toxoplasmosis and there's toxoplasmosis. And there's at least 2 serologic types of toxoplasmosis. And the one from the more common one in South America has, and I don't know what the acronym stands for, ROPS, I believe, is the agent in it that makes it much more aggressive. So I agree with Dr. Dunn that this might have come from a large part of the South American cohort where they have a more severe form of toxoplasmosis.
If you want 2 really, really nice articles on toxoplasmosis, if you look at the American Journal of Ophthalmology, Gary Holland's Jackson Memorial Lectures, he published part 1 and part 2, and that tells you pretty much everything you'd ever need to know about toxoplasmosis. They're really, really good articles. And he talks about the different strains of toxoplasmosis. So as Dr. Polito is saying, that the strain that's more prevalent in South America is more likely to be virulent, more likely to cause bilateral toxoplasmosis. So there are different responses.
So we have 2 minutes left for case 3. As a 27-year-old male presenting for a second opinion on retinal findings in both eyes.
So we have a wide field color fundus photo of the right eye. Vision is good at 20/25. Media is clear. Disc margin looks sharp. We do have some peripapillary atrophy. Vessels look normal in their coursing caliber. Attention is immediately drawn to the macula where we see these scattered kind of hypopigmented lesions throughout the entire macula, as well as possibly in the mid-periphery. It's hard to say. It doesn't look like they're all within the vasculature. They're kind of scattered throughout the periphery. I don't see any hemorrhages. These spots up here are possibly artifact just from the Optos camera. Hard to say for sure.
And just to move along,
yeah,
I had similar findings.
Yep. Yeah, so similar. Yep. Okay, so here we have a fundus autofluorescence of the right eye. We kind of see this speckled granular pattern of mix of hypo and hyper autofluorescence involving the entire macula, and then kind of in a wedge-shaped pattern out to the nasal periphery, and then kind of more towards the outer portions of this hypofluorescence, you see these hyper autofluorescent spots.
And similar findings in the left eye.
Yeah,
correct?
agree. And here we have an OCT image of the right eye horizontal cut, and this infrared image highlights nicely these hyperreflective spots throughout the macula. And then going over to the B scan itself, vitreous is clear, intraretinal layers look well preserved, choroid looks normal, but then we see kind of this pretty significant loss of the outer retinal layers, ellipsoid zone and ISOS junction, although it is well preserved in the fovea, which explains the good vision of 20/25. And then we see these kind of areas of clumping. I don't know if this is pigment clumping or migration. And then, yeah, similar cuts in the vertical, similar findings in the vertical cut. We do see more prominent, this looks like pigment clumping here.
What kinds of things would you be thinking about for this patient with crystals in the retina?
Yeah, so we have a bilateral crystalline retinopathy in a relatively young patient, I believe. So, things that come to mind when we think about crystalline retinopathies, you want to think about medication-induced etiologies, self-tanners like canthaxanthine, methoxyfluorine, tamoxifen, you want to get a good medical history, and then systemic conditions like cystinosis. You can see hyperoxaluria and more end-stage renal disease. So again, medical history is really key. And then you want to ask about, any recreational drug use like talc retinopathy, certainly like off-label or more street use of kind of injections or fillers. So you want to ask about that as well.
So you hit on all of those things. On history, we learned that the patient had no history of renal stones or kidney disease, did not use IV drugs, no family history of blindness or eye problems, and his only medication was an albuterol inhaler. So on anterior exam, we see that the patient actually had perilimbal crystals. And with this constellation of findings, he was actually sent for genetic testing and found to have found to be homozygous for a CYP4V2 mutation, giving him a diagnosis of Beatty's crystalline dystrophy, which is a progressive chorioretinal degeneration that's characterized by the presence of yellow-white crystals and lipid deposits in the retina, and in some patients, the cornea as well. Just moving along. So this is a representative photo showing these perilimbal corneal crystals here. Dr. Polito, just a question for you. How would you counsel this patient on his long-term visual prognosis?
So it does progress, and we talked about it because he's a professional. I think the important thing, though, is so common in East Asians, much more common than South Asians, that I told him that probably there will be in the next 5 to 10 years some therapy for him.
Great, thank you.
Oh, and I think it's also important that these crystals go away with time, and they disappear as more atrophy occurs. So they're harder to find in older patients in their 30s and 40s as the atrophy worsens. So you look very, very carefully for them, and also the perilimbal crystals decrease. So it was really nice to see, these beautiful pictures in a younger patient.
Thank you.